Influenza season and are after cardiac surgery by Fátima Narea. Definition: undergoing cardiac surgery during the influenza season is associated with increased likelihood of development of acute respiratory syndrome (ARDS). Acute respiratory distress syndrome or ARDS is a serious inflammatory lesion of the lungs that causes dangerously low levels of oxygen in the blood. Called hypoxemia, ARDS can lead to a number of serious problems. It is a deadly, so immediate attention is needed. One such risk factor might be asymptomatic respiratory viral infection, for example. Influenza, which could prime the lungs for ARDS, is patient with another other risk factor. Patients who undergo cardiac surgery could potentially carry this virus yet have no clinical sign or symptoms.
Sean Krause, but he doesn't remember any of it.
I believe I was under for 45 days.
Unconscious, on a ventilator to help him breathe, after a case of the flu turned into a potentially deadly condition called ARDS.
It's an acronym for acute respiratory distress syndrome, which it's a form of acute lung injury. In other words, the lung, the tissue of the lung has been injured by something. And this is kind of the classic ARDS picture where we have these dense consolidations on both sides of the lung.
Mayo Clinic Dr. Richard Oakler says that something could be a traumatic injury, a bacterial infection, or in this case, a flu virus.
And sets off a big inflammatory response. And that inflammatory response is really at the heart of this ARDS.
Here's what happens. Your lungs are made up of millions of tiny air sacs. They're in constant contact with your bloodstream, which carries oxygen throughout your body. Normally, barriers prevent water in your bloodstream from flowing into your lungs. When ARDS strikes, barriers break and fluid fills your lungs.
That brisk inflammatory response in the lung now can pass through the bloodstream and throughout the body. And so you get a bad systemic response that can lead to other organ failures and ultimately the death.
Dr. Oakler says close to 40% of all people who develop ARDS don't make it.
I think my lucky stars now, I know that.
Sean's treatment included medication to target the underlying infection and a ventilator to support his lungs.
Ventilators or the breathing machines are really life-saving because we were really able with the machine to help him breathe while his lungs were healing.
Dr. Jeff Rabotin heads the respiratory care unit at Mayo Clinic. He says for many patients like Sean, ARDS can be very tough. There was a time, Sean says, when his family gathered because things looked grim.
They didn't expect me to live. I know how close I was to pushing daisies, if you want to say.
But Sean did pull through. Every day he's getting stronger, healthier, and ready to head home. Back to life.
I'm just thankful to be here.
For Mayo Clinic News Network, I'm Vivian Williams.
Application in medicine. The incidence of ARDS after surgery during influenza season with the incidence of ARDS after surgery during season with few influenza cases in a retrospective cohort study involving patients who underwent cardiac surgery between January 2009 and January 2012. ARDS developed in 5.1% of the 740 patients who were admitted to the intensive care unit after cardiac surgery during baseline period. ARDS developed in 5.6% of the 984 patients in the period between baseline and influenza season and in 9% of the 289 patients during influenza season. All ARDS cases occurred within the first 26 hours after surgery.
May develop acute respiratory distress syndrome, also known as ARDS. In ARDS, the affected part of the lung is not the airways. Rather, the affected part of the lung is at the alveolar level. ARDS is caused by leaking of fluids into the tiny alveolar sacs of the lungs. So, for example, Here is one magnified alveolus. And normally, oxygen that is inhaled into the alveolus is supposed to diffuse into the blood so that the blood can deliver the oxygen to the body. But in ARDS, fluids fill the air sac. The integrity of some of the alveoli will be compromised, often leading to alveolar collapse or atelectasis, and this will ultimately compromise gas exchange. So as a result of diffuse alveolar collapse, the lung will appear to shrink on a chest x-ray film. Collapsed alveoli may also result in refractory hypoxemia. Refractory hypoxemia is hypoxemia that does not correct with the administration of supplemental oxygen. In other words, you can try to administer high levels of FiO2, but because the alveolus is collapsed and compromised, oxygen concentration alone will not correct the hypoxemia. Correcting refractory hypoxemia will require a recruitment of the alveolus, which is a reopening or a restabilizing of the collapsed alveolus. The oxygenation status of the patient is also one of the ways in which we classify the severity of ARDS. So to determine the oxygenation status, the clinician should perform the PF ratio, which is simply the PaO2 divided by the FiO2 of the patient. Here you can see the classification of the severity of ARDS, as well as the mortality risk. So improving oxygenation will be one of the challenges in treating ARDS. But how can we get oxygen in if patients with ARDS have a difficult time getting volume into their lungs due to the fact that the alveoli are collapsed? Reopening collapsed alveoli will require an immense amount of patient effort. Additionally, the lung will tend to recoil upon inhalation. In other words, even if the patient does inhale volume, the lung will immediately want to recoil and exhale. This ultimately leads to shallow and rapid breathing. So that begs the question, what are some strategies in modifying our ventilator settings and treating patients with ARDS? And the answer to this question is coming up in the next lessons, so stay tuned.
Pros and cons. Pros. If the ARDS is acute, it can be cured in a matter of days or weeks early, and prolonged use of mechanical ventilation in the prone position significantly improves mortality rate in patients with severe ARDS. Cons. There may be complications such as blood clots, pneumothorax infection, and pulmonary fibrosis.
USMLEFasttrack.com. The section we're going to talk about today is from First Aid for the USMLE Step 1, 2013 edition. Page 556. What is acute respiratory distress syndrome? Acute respiratory distress syndrome is a life-threatening lung condition that prevents enough oxygen from getting to the lungs and into the bloodstream. What are all the causes that can lead to acute respiratory distress syndrome? Acute respiratory distress syndrome can be caused by trauma, sepsis, shock, gastric aspiration, uremia, acute pancreatitis, or amniotic fluid embolism. Describe the pathogenesis of acute respiratory distress syndrome. In acute respiratory distress syndrome, one of the causes that we just mentioned is going to cause diffuse alveolar damage and increase in alveolar capillary permeability. Now, when there is an increase in the alveolar capillary permeability, there is going to be a leakage of protein-rich material along with neutrophilic substances into the alveoli. This protein-rich material is going to cause the formation of the intra-alveolar hyaline membrane, and the neutrophilic substance is going to cause damage to the alveolar wall. So basically, in acute respiratory distress syndrome, there's going to be high amounts of fluid that will end up getting into the alveoli and cause damage there.
Issue applied in Ecuador. In annual flu epidemics, attack rates can range from 5% to 20% in the general community and up to more than 5% in close population groups.
Let's talk about acute respiratory distress syndrome. Acute respiratory distress syndrome, also known as ARDS, is a pretty severe respiratory issue, and it is specifically a non-cardiogenic pulmonary edema related to systemic inflammatory response. So let's break that down. Pulmonary edema. What pulmonary edema is there is fluid inside the lungs. Okay, edema, fluid swelling, pulmonary in the lungs. That's different than pulmonary effusions in that in edema you got fluid in the lungs, in effusions you got fluid outside the lungs. So this is swelling of fluid inside the lungs, non-cardiogenic, so not related to the heart. It's not due to heart failure. It's not due to decreased cardiac output. It is due to something else, something respiratory, okay? And it's related to a systemic inflammatory response. And this could be, when I say systemic, either the whole body, such as shock or sepsis, or something due to the lungs themselves. So let's talk about the causes. Okay, what causes the lungs to have pulmonary edema that's not related to the heart? Pulmonary embolism. So you got a blood clot inside of the main arteries to the lungs, and so fluid backs up into the lungs, pulmonary edema. Due to inhalation of hot smoke or toxic gases. You inhale it, it damages the inside of the lungs, and now they're inflamed, just as if you were to have a burn on your arm. They're burned on the inside, they're inflamed, they're leaking fluids, pulmonary edema. Pneumonia, same thing, you got damage to the insides of the lungs. Aspiration, you inhaled some food, and now you got bacteria in there, and it's caused some damage to the inside of the lungs. A near drowning incident, your lungs are full of, say, chlorine water or nasty water, and now you have bacteria or some chemicals in there, or just a damage from trying to breathe thick water. Water's thicker than air. It can cause pulmonary edema. Signs and symptoms. So a big sign you'll see here is your patient's oxygen saturations are going to be very low, and you'll put nasal-canal on, doesn't do anything. You put a mask on them, it doesn't do anything. Because the problem isn't getting oxygen to them, is that their lungs aren't working. They're not exchanging that oxygen. So you put all the O2 you want on them, but they're going to stay low oxygen levels. They're going to have shortness of breath and dyspnea. They're not getting oxygen levels, so they're going to be cyanotic. At this point, it's severe enough, it's not getting to the brain, they're going to have confusion. The heart's going to try to compensate by increasing its heart rate, but there's not really doing any good, and you're going to see the blood pressure start to drop, and your lungs are going to sound like crap. You can hear wheezing, you can hear rales. When you do your labs, you're going to see low oxygen levels, and because they're not getting oxygen in, well, if you can't get oxygen in, you can't get carbon dioxide out. So you got high carbon dioxide, that's hypercapnia, and you're going to have acidosis. It's going to be respiratory acidosis, because you can't get the carbon dioxide out, and so that is going to cause respiratory acidosis. Diagnosis, you can do a chest x-ray, and this is going to show the pulmonary edema, but you're going to also run an EKG, and from a chest x-ray and EKG, you're going to see it's not related to the heart. Treatment, basically you can't suck the fluid out of the inside of the lung, so this is going to be a long-term treatment. The patient's going to need intubated, and they're going to need to be on a ventilator, and they're going to probably be in ICU for quite a while if they survive before they make it out. So really, you got to let the lungs heal on their own. Just some quick tips about ventilator support. You're going to be monitoring them. You're going to be listening to the lung sounds. Make sure they don't have a pneumothorax, which is where you don't hear any air from that lung. You're going to want to monitor their vital signs regularly, monitor their EKG, monitor their heart. You're going to want to suction them as needed, do oral care. You want to prevent infection so they don't get pneumonia on top of whatever else they have going on. You can do this by making sure they're getting antibiotics if it's due to sepsis, and you want to give them antibiotics. And you want to also treat the cause. If they're in because they have pneumonia or sepsis, they're also going to need antibiotics as part of their treatment. And so acute respiratory distress syndrome, this is going to be an ICU diagnosis, and they're going to be needing more than likely intubation and a ventilator.
Conclusion. For the relationship that we found between influenza season and ARDS after cardiac surgery to be of clinical value, research is needed to determine whether Perioperative strategy aimed at preventing, detecting, or treating subclinical influenza might reduce the number of patients in when ARDS develop.
I'm here to talk about acute respiratory distress syndrome. It is one of the medical condition with devastating consequences. Usually the breathing is usually effortless, but when it becomes an effort, it is called as a distress. That's why it is called as distress syndrome. It's also called as an acute respiratory distress syndrome because it is very rapid. You don't have much of a time to intervene in between, so the action should be quick. It has to be detected early. Why it happens, an acute respiratory distress syndrome? It is usually because we have tiny pockets in the lungs. They are like air-filled balloons. And these balloons, they get filled with the fluids. And there are multiple reasons for that. When the balloons get filled, the oxygenation doesn't happen. The peripheral organs doesn't get the oxygenation, and it will lead to multi-organ failure. There are multiple reasons for the fluid to accumulate in these tiny pockets or tiny balloons. One is the most common one, which is the lung infection, which is also called as pneumonia. There are many other reasons, like whenever the patient has a chest trauma, or can be inhalation of toxic fumes, or it could be because of drowning or aspiration. So all this leads to an acute respiratory distress syndrome. The awareness among acute respiratory distress syndrome is not so profound. So that's why the detection will be delayed, the presentation is delayed, and the treatment is also delayed. So what is the treatment for acute respiratory distress syndrome? Mechanical ventilator is a savior here. It is one of the mainstay of the treatment. Many researchers have shown the settings in the mechanical ventilator is the one which determines which patient lives and which patient dies. And the quality of the care, including the intensive care setting, including the nursing personnel and the doctors, has to be very high to manage an ARDS patient. Any delay or any mismanagement will lead to fatal consequences. The mortality is very high in the case of acute respiratory distress syndrome. In spite of being on mechanical ventilator, the patient can deteriorate, and there are some other maneuvers which are called as rescue maneuvers. These rescue maneuvers can be done on the ventilator, or it can be taken over by another machine. One of the cheap and inexpensive method is recruitment maneuver, where you inflate these fluid-filled balloons so that the oxygenation will be better and the organs doesn't suffer much of a damage. There is a cheap and convenient method. One step further is also called as a proning. Proning is where you make the patient lie down on flat in the stomach and you ventilate the lungs which are not ventilated earlier. Another last method, when all these fails, there is a very extremely invasive and highly with high cost, it is called as an extracorporeal membrane oxygenation, where the function of the lungs will be taken over by another machine and the lungs are kept at rest. But this has got a huge financial burden on the patient's relatives and patients. Among all these maneuvers, the proning is the most effective method, and even the studies have shown that the proning is the easiest way and also the best way to help the patient with acute respiratory distress syndrome. The awareness of proning is not so profound, as I said before, but nowadays it is becoming more and more equipped in all the hospitals. It requires a very trained profession as well as a very skilled nursing personnel also, and also a good education to troubleshoot all the problems.